All right, and so now we have our keynote speaker, Mr. Tom Duvall, who is the Division Director of the Division of Special Populations and Projects in the Seamless Care Models Group at CMS Innovation Center. In that role, he oversees 3 payment model tests focusing on improving care for beneficiaries with kidney disease, which are the ETC, KCC, and the IOTA models, which we'll talk about, and 2 payment models focused on rural hospitals. He has worked with CMMI for over 10 years and previously worked with the Medicaid policy and financial consulting for Mercer Consulting. And thank you so much.
Hey everyone. Thank you all for having me here. It's exciting to be here. So I'm from the government, from Medicare, from the Innovation Center. So the Innovation Center was set up in 2010 as part of the Affordable Care Act to test out new and different policy approaches to paying for care with the goals of improved quality and lower costs. So I want to start off with intro, and there's already been a lot of great intro by a lot of folks today, but just to show why CMS is so focused on kidney disease, and some of which were covered, some of which were not. So one is that CMS is the dominant payer, that there's the special eligibility for Medicare and the primary or secondary payer for about 80% of people on dialysis. 2 is it's a very sick and expensive population, about 6 times as expensive as the average Medicare beneficiary. About 45 to 50,000 of that is dialysis costs, but the rest of it is due to extra physician costs, hospitalizations, from being such a sick population. It's one with easily identifiable provider roles and care patterns. This one's a little bit different. I know we're at the chronic disease research program here, but that's one thing where kidney disease is sort of, and kind of can be seen a little separately, where we can identify nephrologists and dialysis as the special needs for the patients. It's a structurally underserved population, as has been discussed, very high proportion of dual eligibles, and very big racial inequities in terms of who gets ESRD in the first place. And finally, it's one that's growing. You know, in some ways, this is a good thing, as it shows that the long-term trajectory is positive as mortality is decreasing overall, but also the combination of an aging population and a lot of the effects of diabetes and high blood pressure keep leading to an increased prevalence of ESRD. So what I want to focus on, there's 2 slides here. So it's basically showing what is best for the beneficiary at each stage of the disease, because it's different. And I think I put this up front because this is important policy framing for what we're trying to do. So the goal is at each stage of the disease that the patient is getting the best care from the right provider at the right time that can sort of help them with what their needs are and just make sure they're even getting the care that they're hoping for. So we have the optimal journey up top and the suboptimal one below. So initially, and this is also good, just a good journey to see, and we have another graph later on that'll also show this, just how complex the journey is and its different needs at different stages of disease progression. So it starts with primary care, so making sure that you get treatment for whatever secondary condition is causing this, as well as getting that initial referral to a nephrologist and identifying that kidney disease is an issue. It's called a silent disease for a reason, because CKD is mainly symptomless. But once you get ESRD, it's very symptom-full. So once you get to a nephrologist, the goal is you get that timely referral, you get that early care, you get the work and the necessary lifestyle changes and pharmaceutical interventions that help slow down and really manage the progression of the disease. You also then begin to have the conversations about renal replacement therapy. What is the best option? Which modality of dialysis? How can we start thinking about transplant? And is dialysis even the best option given the goals for patients? And then assuming a beneficiary does move over to dialysis, that it's a smooth, planned start, not crashing an outpatient in a hospital setting. And then also that they get engaged, that they get coordinated care while they are a dialysis patient to help deal with all their myriad health needs, and that they are really engaged and brought to the transplant process. At each step in that process, it requires active intervention, coordination between different provider types. And unfortunately, it's something that we see a lot of places and a lot of beneficiaries who do not get that level of care at each step. And it also stinks because even missing one of those steps has some pretty negative effects for the patient. So I want to first start with the CEC model, the Comprehensive ESRD Care Model. So CMMI started in 2010, and this was our first major model related for ESRD patients. And the idea behind this was looking at overall Medicare A and B spending for hemodialysis. I'll say on a personal note, it was kind of fun making these slides because I was looking back to slide decks I'd made in 2016. So, it's sort of fun doing that, and that's why you get this lovely formatting PowerPoint here. So in general, CMS has been, given that first slide, CMS has been doing a lot in the kidney disease population for a while, and with a lot of focus and a lot of different quality efforts. But most of it had been focused on that portion in yellow for you all, which is about dialysis care, where we came up with a quality improvement program for patients on dialysis. There was dialysis facility compare, and I think a big focus on better dialysis care. However, if you look at this chart, this lovely pie graph, 2/3 of the spending was for care outside of dialysis. And another way to look at it too is that yellow portion is fixed spending mostly, given that even if you have the healthiest dialysis patient possible, they're still going to have this level of spending. But the other 2/3 could be affected and potentially reduced through better care, through avoidable hospitalizations, and by ensuring that people get their dialysis. So I think the other major context is that CMS had already done other ACO models. How many folks in the room have heard of ACOs? Just to calibrate. Okay, cool. So we've done some other ACO models, which again is that same idea of coordinated care and holding the physicians or whoever the primary caregivers are for the patient accountable for the total cost and quality of care for patients. So we'd already done some efforts, and the idea was let's test this out for this population. So the idea was to do this new model where folks would form ESCOs, ESRD Seamless Care Organizations, which was our fancy term for ACOs, basically focused on caring for patients on dialysis, with the idea that that legal group would be held accountable for the cost and quality of care. So it was focused on where a beneficiary went for dialysis and based around the relationship with the dialysis provider, where that would lead to a beneficiary becoming aligned and that ESCO becoming accountable for their total cost and quality of care. Nephrologists were required to be required to be a part of it, but it was mainly focused on the relationship with the dialysis facility. So he said cost and quality of care. So the way we did cost was looking at, we sort of took what we project their spending would look like using historical spending trended forward, and then compared it versus what the actual expenditures were. And this is done in a lot of different CMS programs, but the idea is projecting a counterfactual and then seeing how well they perform against that counterfactual. The key to this is that it's about all Medicare A and B spending. So every doctor's visit, every hospitalization, every use of post-acute care, all of which was not being coordinated under the status quo, and one that we are sort of hoping that with greater accountability could lead to better results for patients in those areas. Quality also an important part of this. Now, there is a sort of inherent quality aspect. We'll get to this in a bit, but reducing utilization, this is still fee-for-service Medicare, where patients can go to any doctor they want and patients can sort of have control there. But reducing utilization most often means if you keep someone out of the hospital, that's sort of the ultimate win-win-win for all of this, where it's obviously good for the patient. It's good for CMS, who's not paying for that hospitalization. And then the goal is to then make it good for the participant in the model, who then gets some portion of the shared savings that accrues from from the money that Medicare saves. So how do we think of success, and how does CMS evaluate a model? So we have in the Statute of the Affordable Care Act, basically 3 official standards. Can it improve quality without increasing spending, reduce spending without reducing quality, or improve quality and reduce spending? So 3 is the goal. 3 is really hard. Frankly, 2 is quite hard too. And we'll sort of talk about some of that in a bit. But in general, the goal is we are trying to do both of those things while at the same time also making it a good experience and sort of reimbursing the model participants for a lot of their efforts that they are putting in for the model. So those are the official ones. The other ways that we look at it is participation. To what extent did we actually get people interested in participating and joining into the model? And I think CEC was a success in that way, given that we had up to 37 ESCOs at our maximum level with, I believe, about 80,000 beneficiaries. Interest and engagement from interested parties. That also happened, where we got a lot of great engagement sort of across the community, the patient community and provider community. ASN heard from once or twice. And then also care transformation efforts. To what extent did that kind of catalyze a lot of the reforms in the way people care for it that we were really hoping for? So we saw a lot of that. So going through this now, the official numbers, the actuarial savings, sort of how they did relative to a benchmark. Our model showed approximately 3% total savings and about over $300 million in shared savings paid to model participants. We also have at CMMI an independent evaluation, who are folks who still within the group, but they conduct their own evaluation of what the results were versus a matched comparison group. So trying to make it pretty rigorous there. Their results did show a reduction in spending, but less than the amount that we ultimately paid out in shared savings. But they did show some great quality results. So a 3% decrease in number of hospitalizations and a 0.4% subsequent increase in the number of outpatient dialysis sessions. 5% fewer hospitalizations for ESRD complications, 5% less likely to use a catheter, and improved phosphate binder adherence. And that's a lot of really good quality outcomes for patients. That's nice to see. We also saw sort of an interest that grew over time as more people joined the model in 2017 for year 2. We more than doubled the size of the model and just had a lot of strong interest from the community and a lot of discussions about next steps. But it's not only important of what did we see, but what did we not see? In general, for all of these, we are conducting policy experiments here to try to see what are the effects, and then kind of how do we build on it and how can we improve? So what did we not see? Integration with primary care. And some of these are sort of known structural defects that it is very difficult to create one single effort that can encompass, especially within kidney care, given that full spectrum. But it showed that if we wanted to affect these things, it would take more explicit policy efforts. We didn't see effects on CKD care, not effects on the transplant process or on modality choice. So to help deal with that, then we came up with some new models. So as Michelle talked about there, this was all announced in 2019 by President Trump as part of the Advancing American Kidney Health Initiative, along with a major reform to OPOs that we'll actually talk about in a bit. But these were announced in 2019, and there's 2 models that we're going to go over here. The ESRD treatment choices model, which we'll talk about second, is our mandatory national home dialysis model. And kidney care choices is our sort of CEC 2.0 model that's focused on coordinated care and really trying to expand the spectrum of care to focus on CKD patients all the way through to ESRD and hopefully to transplant. So KCC, what is it? Similar kind of general deal to CEC. What we had seen was that the general idea of coordinated care worked, but that there were several sort of tweaks to be made and kind of adjustments to be made to better accomplish the goals that we were hoping for. So we came up with 4 tracks within KCC. Basically, there's a nephrologist-centered one called Kidney Care First option, as well as 3 different payment tracks for the different ACOs there. And the idea is that those are coordinated care. So it's all the different provider types working together, heavily focused around nephrologists, but can also work with transplant providers, dialysis facilities, and others to coordinate care. So key changes, a few different ones kind of based on what we'd seen before to really try to achieve the goals there in slide 2. One is, and the biggest one, honestly, is focusing on CKD beneficiaries, where there comes a point within the progression of kidney disease where kidney disease becomes the most important diagnosis. For the purpose of this model test, we put it at CKD4, and it was a decent guess at the time, given that most CKD4 patients will likely progress, but a lot of CKD3 patients will as well, and some CKD4 patients won't. But the idea is it was to get the people who are most likely to progress further along all the way to end-stage renal disease. We also include beneficiaries after they receive a transplant and include financial incentives to help folks through the transplant process. We focus on the relationship with the nephrologist instead of that with the dialysis facility, really trying to get that idea of longitudinal care relationship with the nephrologist as the patient transitions from being CKD all the way into ESRD. And then including some additional Medicare benefit enhancements and adjusting nephrologist payments directly. So not just sort of focusing on that care relationship, but also adjusting the way nephrologists are paid to help achieve the outcomes that we're looking for. So talking about that, what does that include? It basically means paying nephrologists a little more for CKD and doing it through a capitated quarterly payment. It means increasing the amount paid to nephrologists for prescribing home dialysis. It means a bonus payment for getting folks all the way through the transplant process and kind of doing the necessary work on the front end to help get folks into the process, get them active, and as well as working on post-transplant care. As well as an upward or downward adjustment for folks in the kidney care first option based on their results, and shared savings and losses, the same framework that we did within the CEC model, focused on if you save Medicare some money based on our calculations, that we would share some of it back with you. So what are the results? We only have results so far, official results for 2022. This recently got published on our website, which is very exciting. So the answer is some good news and some sort of TBD. So some of the good quality results to highlight is some significant increases on home dialysis rates, which is, I think, pretty exciting. This is part of the, this was part of the goals when everything was announced. The idea here is that if you can reach patients a little earlier on in the process while they're in CKD, and you have that focus also on modality choice and good dialysis starts, that you can see some real movement there, which I think was pretty exciting. No significant change in transplantation rates, but a relative increase in active waitlisting. The one that's probably the single biggest result is a statistically significant increase in optimal ESRD starts, meaning patients who start outpatient in a dialysis facility with a fistula or with home dialysis. It basically implies that they've had a planned start, not in the emergency department, and have sort of gotten that necessary pre-ESRD care to really get a good start there. What we didn't see, though, was any statistically significant change in payments or in hospitalizations or ED visits, which are some of the key, most important metrics that we're really looking at here. The other model we have is the ESRD treatment choices model that we're operating at the same time. It started in 2020. That's mandatory across 30% of the country. And the idea there is to increase the rates of home dialysis nationwide through different payment adjustments based on dialysis facilities and nephrologist rates of home dialysis and transplant waitlisting. That model's shown some null evaluation results so far with no statistically significant results. It's been one that's been somewhat confounded by a few different things, given that COVID happened, which also not only was very disruptive in and of itself, also very disproportionately affected the in-center dialysis population. Medicare Advantage, a lot of beneficiaries in fee-for-service Medicare have transitioned to Medicare Advantage during this time. Just basically, it's a big change in the patient population. Another piece was just the rollout of the presidential level initiative around home dialysis. That doesn't happen too often, that the president gets on there talking about a big initiative. Kind of messes with randomized control trials there and contaminates the comparison group a little bit. And then also just the national nature of providers, where we're dealing with national dialysis companies who we had heard implemented a lot of things across their companies rather than just in the targeted intervention regions. So where does that leave us? I just want to talk through kind of a few ways to think about the future and how we build on it and sort of what the third and fourth generation of models could potentially look like. So one big point here is Medicare Advantage, where until 2021, only individuals already enrolled in an MA plan were eligible for MA coverage. But once that changed, the proportion of beneficiaries dialyzing with Medicare fee-for-service fell a lot. And now about half the beneficiaries in Medicare are on Medicare Advantage. And what this means is that, CMS has built a lot of quality and value-based care infrastructure around kidney disease, and none of that is directly replicated in Medicare Advantage. So there's no bundle to pay for dialysis or new drugs. There's no ESRD QIP, and none of these value-based care things. Now, that's both a challenge and an opportunity, because there's the opportunity to sort of work with MA plans to come up with what the right measures are to measure performance and to ensure quality care. But these are sort of discussions that kind of need to be happening now as there's been this rapid transition here. But what this also means, and sort of the definite upside of this, is that between MA and the Kidney Care Choices model, approximately 80% of beneficiaries in Medicare with ESRD are receiving the benefits of coordinated kidney care. So that's good, at least theoretically, where it's the goal that that means that 80% of the patients have providers that are looking out for them based on their cost and quality and are sort of being held hopefully to that same set of incentives there. The other one I wanted to hit is the transplant system. So this is a great graphic put out by the SRTR that is kind of intentionally complex. But what this shows, so if you remember, the first graphic I had showed all of the different actors and their role throughout the life cycle of a kidney patient. This graphic shows all the different actors in their role throughout the transplant process. So you can see the patient in the middle. The patient is that lovely teal line. But you can also see the other one that's almost completely in the middle there is that lovely dark bluish line, which is the transplant center, who controls most of the major steps in the process. Now, it does require support from the referring physician or the dialysis clinic to get a patient started, to refer the patient to the clinic and educate them about the transplant process and help to ensure that they are healthy enough for a transplant. But the center ultimately is the one who controls evaluation, who controls listing, who completely controls the living donor process and controls which organs to accept and who to transplant. Now, you can also see up top there the role of the OPOs and the donor hospitals. Donor hospitals are the hospitals, just refers to a hospital where somebody dies and becomes a patient for organ donation. And the OPOs are the ones who have the regional monopoly to procure organs from all of the donor hospitals in that region for folks who die, and then offer it to the transplant center. So what I think the point here that we see is that you see the transplant center line there and their big role in the process. There's also one that didn't fully come through with the regulator, which is in this case CMS, as well as HRSA and OPTN, which I think also applies all the way across this. A role kind of overseeing each step in the process with the goal of aligning incentives for each actor in this process. So looking at this, and just wanted to highlight some of the major ones that are happening. So CMS finalized its OPO conditions for coverage requirements that include certain minimum standards about number of organs transplanted based off of the ones that they recover within their donor service area. It's the first time they're sort of set with a clear performance target with the idea that they could potentially lose their contract to manage their DSA. We also proposed at CMMI the IOTA model, increasing organ transplant access. We're governments, we got to talk in acronyms for everything. But this proposed payment model basically says, what if transplant centers did more transplants? And offering incentive payments for increasing their number of transplants, helping more folks through the process, and focusing on being more efficient through the process there. And then HRSA has also been overseeing that OPTN modernization effort, focusing essentially on regulating the regulator, given OPTN's unique role that HRSA helps to operate, and really helping to strengthen oversight there. So I think the goal there is kind of pushing across each of these actors in the transplant process with the goal of getting more patients through the transplant process and ultimately getting the results that we're really hoping for. So where we are now, we proposed the IOTA model in May, and comments were due back in July. We are currently working on finalizing the model. The model we had proposed a start date of January 1st, 2025, and we're sort of working on finalizing it now. And it'll be very public when it is final. So yeah, appreciate this and hope this was helpful. Thanks all.
Hi, thanks for a great talk. So my question is about Medicare Advantage. I think most people would say that at its best, it really is a truly coordinated care model. At its worst, there's an emphasis on prior authorization and utilization restriction, and maybe people will end up worse off. Given how new this policy is that ESRD patients can be in Medicare Advantage, can you tell me a little bit about CMS's plans to either sort of learn from those coordination efforts or to monitor any sort of stinting of care in this pretty vulnerable population? And do you feel like you have the data to do so?
Yeah, I think that's a big question that sort of keeps a lot of CMS up at night. I mean, it is one where it's a much less data-rich environment. We don't get the full encounter data. It's not the same level of data submitted there as is like Medicare claims data. I think it's one we're grappling with of how to build that policy infrastructure to support these patients. And it's one where I think there's a real value in, I think, sort of pushing and thinking about what is appropriate care and how do we measure that for these Medicare Advantage patients, given that this has been a challenge for decades that CMS has done the work on within fee-for-service.
I have a question about, a lot of policies to improve quality can be disparity neutral, can increase disparities, or can reduce them. How has CMS been monitoring both the increase in quality cost and change in disparities for the different models?
Yeah, I know we look at that across each of our evaluations there. I think in general, the models are sort of built to, help the overall population, which obviously the population overall suffers from some pretty strong, just inherent within that massive disparities in who gets ESRD in the first place. Also within ETC, we did create separate benchmarks based on the proportion of dual eligibles that each center has. I think recognizing that just the relatively lower rates of home dialysis for dual eligible patients. And I think giving them some extra credit for increasing it more among that population. It's an open challenge, and it's a big one within quality measurement of how do you set standards that recognizes that, certain groups may have lower inherent rates, while also holding the provider accountable to try to achieve the positive outcome that we're hoping for all patients. So that's a challenge. It's one that, pendulums go back and forth on of how to account for that or not account for that at various points. And, it's one that we'll always look at and evaluate the impacts of.
Fantastic talk. I was thinking about tomorrow's questions, threw me off, but I think in kidney care for end-stage dialysis patients, what the standard of care is relatively well defined. And so I wonder if Medicare Advantage plans that are skimping on that to save money, it would be more obvious and identifiable with data. So that was just one thought I had. But compared to other Medicare Advantage in a more general situation where, then the dialysis patients would at least be easier to detect when Medicare Advantage is withholding important care elements from patients to save money. But my question was actually about, of course, I was going to ask about CMS using the policy levers to decide who's getting transplanted to achieve some of these outcomes. It seems like right now, CMS is content to let the OPTN create whatever allocation policy they want for where the deceased donor kidneys are going. And instead, in focusing more on increasing the absolute number of deceased donor kidneys transplanted, but you don't seem to care who they go to, right? So I just wanted your thoughts on that.
Yeah. So we don't really touch allocation, and our model doesn't touch allocation. Allocation is a complex, fraught area, and it's one where we just don't touch that there. I'll say that IOTA, the principle of IOTA is holding centers accountable for their number of transplants and for increasing that number over time. And one of our main principles there is flexibility on how to do it. So centers could look at which organs they're actually using now, and maybe choose to accept more deceased donor organs or ones that they're currently rejecting. They could invest in living donor donation. We see some pretty vast disparities around the country in the number of living donor transplants per center. So it's one where we are being proscriptive about the outcomes we're looking for, but I think giving folks the discretion to figure out how to best do it, given their center and given their individual context.
I thank you very, very much for an excellent talk. And this is kind of a question for you, but also for the other three speakers. We've talked a lot about policy, innovation, and healthcare, but I don't think so far anyone said the word financialization. And I'm wondering, is financialization so much a part, so implicit in this industry that it is almost walked away from the conversation, or is there a value in actually making explicit what the role of highly financialized, highly consolidated actors in the dialysis space are doing to the industry and to your work and to all of your work?
Yeah, I think I had two different thoughts to that. One is, our role at CMMI is to we deal with the system as it is. and kind of try to improve it from there. We've worked with every major actor within the dialysis space and nephrologists and everyone else. We've also built on it. You can see the way that CEC was pretty dialysis focused. And then KCC has a much more diverse array of participants. There's several new companies that came into the field that didn't exist a few years ago before KCC was announced, that I think to help bring some needed competition, some good competition into the space. And we're sort of happy to work with anybody who's willing to meet the requirements there. I think the second thought is that policy and payment policy, it all has a point of view. You know, we could really improve kidney care in this country if every CKD visit for a nephrologist were reimbursed at $10,000 a visit. That would change things. It would. We don't because of payment formulas and a lot of other choices not to. But, you know, every policy is a choice. And I think our thought and sort of what we try to do at CMMI is try to use our levers that we have, which are mainly focused on payment policy, to try to get better outcomes and figure out how to better align the payments and whatever structures there, so that if a center does what is best, or a center or a nephrologist or whoever's participating in the model does what's best for the patient, that they are financially rewarded for it.
Hello. Thank you for that talk. Very insightful. I just have kind of like a tactical question about patient conversions from treatments and dialysis facilities to getting them to do the home-based model. Because I feel like if you have been doing dialysis in a facility, there may be some roadblocks to convincing a patient and their family to do that care at home. So in your experience or intuitively, what do you think are some good practices for someone who may be responsible for these facilities to try to facilitate conversions to home dialysis?
Yeah, you're right. It is hard. Yeah, the phrasing generally is incident versus prevalent patients, where it's much prevalent, meaning the patients that are already on dialysis. And if they are already getting it in center, it becomes very, very difficult to transition there. A few thoughts. One is, you know, again, it's that same thing where we're not proscriptive about which patients to do. We just sort of set the target on the rates and leave it up to the centers who are the ones directly dealing with the patients. I think two is there's a lot of good home dialysis training options out there and like transitional care units to really teach the beneficiaries the benefits of home. And I think sort of show them that it's not as hard and scary as they think it may be, especially if they're used to already doing in center there. I think a third piece is just the idea of looking at larger flexibility. So, you know, the 4-hour shift, you know, the Tuesday, Thursday, Saturday, 9 a.m. to 12 p.m. shift is probably not ideal for everybody. So the model does include other options, looking at self-cannulation and self-dialysis within the center, which is that sort of transition step there, as well as nocturnal dialysis. Sort of looking at, I think in general, the goal for modality choice is find the option that works best for each patient based on their goals. And it's hard, honestly, when patients are sort of defaulted into choosing one without having necessarily made the most informed choice there. But I think the goal is that it's sort of constant discussion of what are the patient's goals, what do they want, and then figuring out the best dialysis treatment for them so they can achieve those.
You know, in addition, I think that speaks to really having patients referred to nephrologists so that planning can be done, and so that education that's necessary to get people to consider home dialysis therapies is so critical, because versus crashing into dialysis and finding yourself on sort of referred to a dialysis unit. So that's also a really critical point of this, is to be able to meet people earlier in their journey, to be able to help them make that decision and work with them so that they can see that home treatment. I know in our program, and I don't know if anyone here is in our program who works on our transitional care unit, but is anyone, Arlene, I don't know, or if you want to make a few comments about it. I'm sorry. Okay, great. Let me hand the mic over to Rita, I'm not on the front line here, but I'm going to hand it over to the front line people who can tell you about it from a practical standpoint.
Well, I mean, this is a program where we're trying to catch people who crash start and who've never had an opportunity to be educated about their options. We do a ton of stuff with our own patients in the clinic, but these are people that we didn't reach and we didn't know. And so they're enrolled in hemodialysis in a unique building that has home dialysis on the second floor and hemodialysis on the first floor. And so they're getting their treatments, but they're spending quite a bit of their time upstairs learning and giving them a full opportunity to develop their options that they didn't have before they started dialysis. And of course, we're aiming to recruit every patient. It doesn't work out that way. And at the end of the day, it's still the right modality for the right patient at the right time.
Just, I think I'm looking at Dr. Barth, I'm thinking about transplant. One other, I guess, plug for home dialysis is, I think folks who do home dialysis, if they're on dialysis, it's almost an easier transition to transplant because they're very much used to providing, taking ownership and providing their own care. And so I don't know what, Dr. Barth, what your thoughts are on that, or Dr. Concepcion, what your thoughts are, but I just, see that these folks who have gone through home dialysis tend to transition to transplant, find that sense of the change to transplant that much easier. I don't know if you want to say.
All right, so wait, just want to focus. Any other questions?
Oh, sorry. So sorry. Sorry.
Thank you so much for the talk, Tom. I had a question in terms of the reconciliation process that CMS goes through, both for the QIP and also the CKCC models and the different models. So when it comes to equity and like the adjustments, like how much transparency is available to kind of see what goes on in terms of factoring different outcomes for different populations, and what, I guess, how does CMS factor in equity when it comes to the QIP and also the CKCC models and the KCC models?
Yeah, I think I can speak to it mainly from our models where we do an independent evaluation that breaks down results in a lot of different ways. And part of it is by different subgroups. So you can sort of see the results there to break it down. It is one where I think ETC has the adjustment that we had in there. There's no explicit adjustments within KCC. We do have a requirement there for participants in the model to do some reporting about health equity data, sort of examining some social determinants of health barriers that folks may have, as well as sort of coming up with a plan and sort of metrics that they're going to track there. So that's one of the big pieces. That's one of the new pieces that's in our model there. We didn't include an explicit financial adjuster. We had done some analyses looking at that and didn't see strong variation between our KCEs across the country because, we're dealing with kidney patients across the country. So there's disparities everywhere. So there's no explicit adjustment there within the model. And again, it gets back to that same question of how do you want to be in a world where you're setting different benchmarks and sort of setting different expectations for different groups there? And how you set that and sort of determine what is the threshold of acceptable care by population is sort of that's a difficult one within the field of quality measurement. Yeah. Yeah.
Thank you so much.